Okay, we are live now, and welcome to everybody who's joined us. We'll keep admitting everyone as they come in. It is a pleasure to have you back for our weekly installment of the Fireside Chat at Boston College with our experts, Nadia Abuelezam and Dr. Phil Landrigan. We'll be joined today by Father Jim Keenan as well, as soon as he completes teaching his class in about 30 minutes. For those of you who are new to the conversation, the name of our program references the Fireside Chats, which were a series of evening radio addresses given by US President Franklin Roosevelt between 1933 and 1944 during the Great Depression and into World War II. Using the radio as a direct means of communicating with citizens, Roosevelt was able to quell rumors and explain his policies in a way that offered comfort and leadership during times of uncertainty and even despair. For these online fireside chats, we're employing another relatively new medium, Zoom, to bring a similar level of intimacy and community to these important conversations. And we're joined each week by two experts from Boston College in global public health. Nadia Abuelezam, Assistant Professor at the Connell School of Nursing, and Phil Landrigan, Professor of Biology and Director of the Program in Global Public Health and the Common Good at the Schiller Institute for Integrated Science and Society. And today at 12:30, we'll be joined by another BC expert, theological ethicist, Father Jim Keenan, SJ, Canisius Professor in the Theology Department, Director of the Jesuit Institute, and Vice Provost for Global Engagement at Boston College. So as usual, we like to start with having Nadia give us an update on the epidemiological numbers and the situation, and then questions and comments from Phil Landrigan, and then we'll move out to an open discussion from there. So thank you all for being here. Thank you, Phil and Nadia. And Nadia, why don't you get us started?
Sure. So thanks for having me again. It's really nice to see so many people logged on and interested in talking about what's happening in the world. So as usual, it was just a week ago that we spoke. It might feel like a month ago, but it was just a week ago. And there's been a lot sort of changing in terms of the information we know and the numbers that are on the ground. So Erik, if you can allow me to share my screen, I will share some of the newest data from the Johns Hopkins site. So I don't know if anybody has taken a look at that lately, but they've actually done some restructuring and revamping to the amount of information that they're actually showing. So you can now look at a world map where you can see that we're approaching about 2 million confirmed cases globally, over 120,000 deaths globally. And then if you go to the US map, which they have added newly here, what you'll see is that we have in the United States about 547,000 confirmed cases in the US with over 23,000 deaths. Their map also has some capability of showing you where the confirmed cases of coronavirus are, and then also where the deaths are. So I just want to sort of raise your awareness to a number of things that are happening on this figure here. So one is that you'll notice that the areas that we've talked about again and again, week after week, in terms of being the epicenters, are places like New York, places like Seattle, and then places like Los Angeles. California has been in the news over the past week with regard to trying to figure out whether or not they've done enough social distancing to really flatten the curve in California. And it does seem like they've actually acted proactively and early enough that they are seeing relatively low numbers of cases in California compared to other parts of the country. I also just want to raise some awareness about some of the other hotspots on this figure here, specifically looking at the areas of Arizona and parts of New Mexico as well. There has been data that has come out in the past day, actually, highlighting the fact that Native American and American Indian populations in the United States are experiencing an increased burden of coronavirus, and especially for their population size in the United States, a non-proportional burden of death as well. And this is new data that's coming out of reservations. American Indian hospitals and databases are now reporting on this information. I also mentioned previously that there was a hotspot in New Orleans, in Louisiana, and we see that that's represented on the map, as well as Florida and Miami in particular. And Florida is a very interesting sort of natural case study in contrast to places like San Francisco. Florida actually took a long time to implement social distancing. We've seen sort of the ramifications of a lot of the spring break behavior that has occurred in Florida, and that has actually resulted in a large number of cases that are occurring there. But New York still remains the epicenter of the epidemic in this country, with over 100,000 confirmed cases in New York alone. And I just want to show you the deaths map here, largely representative of the confirmed cases map, although we are seeing some disproportionate amounts of death in places with large proportions of minority groups and minority populations. And of course, last week we talked about the burden that Black and Latino Americans are experiencing. I think we discussed last week that while many in the public sphere are attributing this disparity to chronic and pre-existing conditions, it cannot be said enough that really what we're talking about here is the effects of systematic racism and the ways in which systematic racism have been implemented into our society, implemented into our healthcare structures. And that's primarily why we are seeing these differences in both testing, diagnosis, and also death rates in this population. The other thing that Johns Hopkins is doing now is they're providing some additional graphs, trying to help us understand how this epidemic is moving. And last week, Phil pointed out that one way we might be able to determine if the epidemic is morphing, is changing, is to look at the evolution in the confirmed cases graph. So whether or not the number of confirmed cases is decreasing might help indicate to us that the epidemic curve is shifting. So this plot here shows you a 5-day moving average of the daily confirmed new cases. And what you can see is that in the United States, which is the green line here, we have an increasing number of new cases, seems to be relatively steady and stable right now, around 30K, but as Phil indicated, we may be on a downward spiral here. And this data can be then compared by country. So here we're seeing that in the US, we have a moving average that is decreasing at the moment, seems that it might continue to decrease. But looking at Italy as an example, who has gone through this ahead of us, this may be a bumpy ride down on this graph in the sense that we might see decreases and we might see increases. And this is going to be related to patterns in how people are showing up to the clinic to be tested, also probably in our country related to testing availability. We are now seeing testing being shifted to the states as a state responsibility now, which is a very interesting turn of events. And I suspect that that will actually change the shape of this epidemic curve as well, because it's going to really render particular people unable to access testing in many places and in many states where resources might actually be poor. So these maps actually help you look at how these trends are changing over time in various countries, and you can compare how the peaks and the ebbs and the flows of these epidemic curves are changing. I just want to note here, it's really important to pay attention to the y-axis and the units on the y-axis. The United States y-axis is much, much higher in terms of number of confirmed cases than any of the other countries on this chart. So it's always really important to look at the units and also to think about the denominator. So those are some of the things that I've been thinking about over the past week. I think one thing that has been written about, something that's been talked about a lot, are these disparities that are occurring among racial groups in the United States. I think the other thing that's relatively new that's come out is our knowledge about asymptomatic infections. There was a study published recently, again, a preprint study, looking at asymptomatic pregnant women who were presenting in New York City to their prenatal care appointments. It does seem like a large proportion of these women are testing positive, about 15%, even without symptoms. So that suggests that we may actually have to be careful about the potential for asymptomatic transmission. that could really drive the epidemic curve in this country. And without more information on how prevalent asymptomatic transmission is, we can't really make accurate predictions about our epidemic here in the United States. So I'll stop there, and I look forward to answering any questions you might have.
Thank you very much, Nadia. I know that the asymptomatic transmission has been a big story, new information about that coming out this week, and new empirical work being done. So I'm sure that will be a part of our conversation ongoing today. Phil?
So thanks, Erik. Thanks, Nadia. So I have three things I'd like to talk about. Let me start by talking about New York City. As you know, I spent 33 years in New York as a physician at Mount Sinai School of Medicine. On the faculty there, I was involved in all the 9/11 work for almost 20 years, my last 20 years in New York. And sorry, small bloody nose. And one of the striking figures, I'm looking at the Johns Hopkins map on my other screen as we talk, is that there have now been 7,300 deaths in New York City itself, and about another close to 3,000 in Westchester County, Nassau County, Suffolk County, and the northern New Jersey counties that are all part of the New York metropolitan area. That's more than 3 times as many people as died on 9/11. It's just it's striking. It's really quite an amazing statistic when you put it in those terms. And I remember vividly to this day how horribly distressed the city was in the aftermath of 9/11, not just for a few days, of course, but for weeks and months, even years. I predict that both the physical as well as the mental health ramifications of COVID-19 are also going to ripple through society, especially in the hard-hit places like New York, and also here in Boston for a long time to come. So that's the first thing. The second thing I wanted to talk about is occupational exposure to the virus. Along the way, I got cross-trained in occupational medicine when I was working for the U.S. Public Health Service, and actually spent a few years working as an epidemiologist at the National Institute for Occupational Safety and Health, NIOSH, which is the federal agency that studies patterns of disease and injury in workers. And one of the recurrent themes in this epidemic and the response to this epidemic, which I don't think has gotten the attention it deserves, is the way that healthcare personnel, doctors to some extent, but much more than the doctors, the nurses, the patient health aides, the other people who work in hospitals and nursing homes, healthcare establishments, how they've been thrown into the breach here with really inadequate levels of personal protective equipment. I mean, it's axiomatic in occupational medicine that the best way to protect people against a toxic exposure is by engineering controls, which means to ventilate the room, to get the toxic material out of the way. And that works in a lot of industrial situations. But in a hospital situation, especially when somebody is doing nursing care at the bedside, dealing with bodily fluids and such, there is simply no substitute for personal protective equipment. And we owe it, all of us in our society owe it to the people that do that heroic work to provide them with the proper equipment. And sadly, we've not done that here. I got an anguish call last evening from one of the senior nurses in the Massachusetts Nursing Association that some of the big hospitals in Boston are now insisting on 2 things. First of all, they're bringing people back onto the wards who haven't done clinical work for a long, long time. I heard of one person who was a 65-year-old nurse, a cancer survivor, and she was basically told she had to come back or it would be her job. And then another thing that's going on is that N95 respirators are being collected at the end of the shift, sent over to a facility in Somerville, run through some kind of a sterilizing operation, and then the same nurse is expected to wear his or her mask the next day. And that we wouldn't think of doing that in the normal course of doing business. The nurses are being assured that those respirators have been rendered sterile, but I don't know that there's any real data to back up that assertion. So I think the whole way we're dealing with the workers here is a vignette that illustrates poignantly how poorly prepared this country was going into the epidemic. We let the emergency supply stocks dwindle. We didn't maintain proper emergency stores of personal protective equipment. And it's the workers, the people on the front line that are paying the price. The final point I wanted to make is something that Nadia and I have been discussing back and forth by email in the intervening week. And that's the question of, will people be properly protected? Will people develop antibodies to COVID-19 that protects them from reinfection in the future? I think the jury is still somewhat out on this because there hasn't been enough future yet for us to do any kind of longitudinal follow-up. But there was a lovely article by one of Nadia's mentors, a guy named Mark Lipschitz, who's an epidemiologist at Harvard, was in the New York Times the other day, and I shared it with Erik, and we can put it out afterwards if you want. And he thinks, he's cautiously optimistic, I think is the right way to put it, that people will develop antibodies and they will be protected, and that once we get widespread antibody testing up and running in this country, we'll be able to determine who is protected against future infection and who is not. And that obviously has implications for individual health, but it also has it provides an opportunity to guide return to work. Because I think one of the big themes we're starting to hear already, and it's going to become louder and louder over the next couple of weeks, is a big push, especially from some levels of our government, to get people back to work quickly. I think part of that is justified economically. Millions of people are out of work. But part of the pressure is political, because elected officials want to be seen to be doing something, and they're willing to gamble with people's lives to look good, to put it bluntly. So if we know who's got antibodies, we can at least make rational decisions about who to put where first, that kind of thing. And I think this, again, we don't have all the answers here, but we have enough information at this point that we have some indicators that we can watch. So I think that wraps it up for me. If Jim Keenan's not here yet, Erik, I'll give it back to you, and if you want to take a few questions until Jim comes on.
That's great. Yeah, thank you very much, Phil. At this point, I'd like to welcome anybody to raise a digital hand or to type a question in the chat box for our speakers. And in the meantime, we can take up a few of the other questions in detail. Father Keenan will be on around 12:30 after he finishes teaching. So we have a few minutes dedicated to this group. And I guess I'd like to offer a beginning question around what we're seeing among governors on the East and West Coast now to develop a sort of multi-state, what the newspapers are calling a pact, and collaborations of some sort. And I wonder if either or both of you have some insights into the value of such work, the risks of such work. Any group of states also has states adjacent to it that are not included in that. And so while it might seem, to be regionally very smart, we know that there are big hotspots in Idaho and just across the border from Oregon, or, et cetera. So could either or both of you speak to the risks and opportunities and state-based collaborations around recognizing when to open businesses and unlock in stages the sort of stay in your house orders that are out there?
I mean, I would say there's no absolute answer here, but in general, I support the actions by the governors. I think it's in the absence of federal leadership, and that leadership is indeed painfully absent. The states have to step up. Fortunately, the states have a lot of power here, contrary to President Trump's assertion yesterday. The states, and specifically the governors, have a lot of power because, as we've said before in this series of conversations, public health is largely a state responsibility in this country, not a federal responsibility. And it's the governors who have the legal authority to take these sorts of actions. And the president really doesn't have constitutional authority to override the governors. I think that the governors, I think that what we're going to see play out over the next few weeks is that the governors of these states that have joined together in the pact are going to want to delay the reopening of business longer than the president. And claims and counterclaims will be made about the politics of this. The president, I'm sure, will claim that Democratic governors are trying to sabotage him. The governors will argue that they're acting on the side of public health. But I would say on balance, it's a good thing that these governors have stepped up. It's not absolute protection, as you say. There are hot spots in the middle of the country. I heard about these 1,000-person Easter gatherings this past Sunday in some places in the South and the Midwest, which, in my opinion, as a public health professional, is madness. But those events are going to generate waves of cases in parts of the country that have been relatively spared up until now. Some of that will spread, but after all, most long-haul travel in the United States is very much suppressed right now. And I think these regional pacts will make a difference.
I also just wanted to say, especially for our students who are in the global public health curriculum here at the school, I mean, we are exactly seeing right now everything playing out to show us that indeed public health is political. You cannot separate public health from the politics in this country in particular. A lot of the responses have been falling on partisan lines. A lot of the ways in which resources have been distributed has been falling on partisan lines. And then we also see the impact of general, political oppression that is occurring for a lot of people of color in this country. And so I think, more than ever, and I see some of my colleagues on the call, like Laura Hake and others, there was a moment where I thought, do I have, as a public health teacher, do I have the responsibility to teach politics in my classroom? And I think what coronavirus has taught me is that I am now required to do that. I'm now required to engage with that because this is really showing us exactly how public health is quite political.
Thanks, Nadia. Can either of you take up Josh's question, Josh Rappaport's question regarding the flattening or not of the curve in Massachusetts right now?
Yeah, this is something that has been getting a lot of attention in the past week, not only in Massachusetts, but in places like Washington State and in places like California. There's been a lot of discussion of, have we flattened the curve? Have we done what we aim to do with social distancing? And I think what this conversation is actually bringing out is now the realization that by flattening the curve, what we're actually doing is lengthening the duration of the epidemic. Right? Essentially what we're doing is we're reducing the number of people who are infected now, but ultimately that means that we're going to have this epidemic for a longer period of time. And again, what this allows us to do is allows us to have our healthcare system catch up. And I'm not sure that second piece, the let's flatten the curve, implies that we're going to have a longer epidemic, has really been understood by the larger public. And I think that that's why we're sort of seeing a lot of this impatience with trying to reopen up, trying to go back to normal, when in reality, I think it's really important to know that, yes, we may have succeeded at flattening the curve, we may have succeeded at reducing the number of infections now, but this has ramifications for the length and the duration of this epidemic that I don't think everyone has really considered.
I agree with that completely, absolutely. But that said, it's still very important to flatten the curve, because what flattening the curve achieves here and now is that it prevents the hospitals and the emergency rooms from being overwhelmed with so many patients that they simply cannot cope. And that's what happened in Italy and what we've tried with partial success to avoid here. I had some information from New York. I've been monitoring the admissions data to my former hospital system, the Mount Sinai system, which is the biggest healthcare provider in the 5 boroughs. And over the last week, the number of admissions has been flat. They're still getting several hundred a day, but it's not an increase from day to day anymore.
And I think it's related to Denise's question in the chat box, which is sort of this idea. Denise asked about the Boston Globe article about herd immunity. And in the Globe article, it essentially said that, you know, social distancing and flattening the curve now may lead to a peak later in the fall. And I just want to emphasize again that yes, we need to flatten the curve. We need to make sure our healthcare system can respond. That does mean that we will extend the length of the epidemic. And that also does mean that when we decide to return to somewhat normal activity after this, we will likely see another spike, another peak in the number of cases that will occur. And I think by pushing that out further, which is what that article had mentioned, and as you say, pushing it out to the fall, what we're doing essentially is buying some time to allow for the development of antiviral treatment that may help reduce the severity of the disease. It may allow us to develop more sophisticated testing and more widespread testing. And it will allow us to have more serological testing that can help us with more targeted response. So I know, and there have been, I will say, a few rogue epidemiologists out there who have been suggesting that we shouldn't be flattening the curve. We should just let it, you know, happen. And then that will reduce the ultimate length of the epidemic. But again, that's going to result in many more deaths, many more casualties that can be prevented. And it is a question of, you know, what do you value more in this equation? And it's, again, this tension about individual liberties and the public good that we come back to again and again and again in public health. So I know that Boston Globe article has resulted in a lot of conversation. I was quoted in that article, and I think the reality is, yes, we need to push this back a bit. We will ultimately need to get herd immunity. We will ultimately need to get the number of people in the United States who's had exposure to this virus up very high in order for this to end. But we also need to buy some time to get some treatment, to get some testing, and to get better technology.
I think thank you, Nadia. I think one of the things that became more apparent with some of the new Hopkins visualizations and some other data over the weekend were the extreme nature of the death rate in Italy relative to other countries and in Spain. And as a non-expert, my understanding is that that's related to the healthcare facilities being overwhelmed, so that they were up in the 12% range as opposed to the 1% range. Is that an accurate reading of that, or just so that the rest of us can understand what the differential might look like in the United States if our healthcare facilities are overwhelmed? There's a gigantic gap in the fatality rates when that happens, right?
Yeah, I think the Italy data are probably a couple of things. Part of it is reporting. Part of it is the fact that Italy has the oldest mean age of any population in Western Europe. And the third part is what you say, that the hospitals got overwhelmed. I would say parenthetically, anybody who argues that people ought to mingle to push up the numbers has never worked in a hospital. You know, that's a theoretical argument put forward by people that don't have on the ground experience.
And just for the students on the call who've gone through sort of our public health coursework, the differences that we're seeing in Italy's numbers and the United States numbers have exactly to do with the demographic transition. This idea that Italy is much further along the demographic transition. They have a much more aging population than we have in the United States. And this could be contributing to the differences in the case fatality rate that we're seeing. Thank you both.
I'm happy that we're now joined by Father Jim Keenan. Jim, welcome. It's good to see you. Father Keenan is the Canisius Professor of Theology here at Boston College. He's the director of the Jesuit Institute and also the Vice Provost for Global Engagement. And among many projects that he's done over the years, he's an expert on the ethics of HIV. And we've asked him to come join us to talk a little bit about COVID-19 and HIV, and of course, whatever else is on your mind. So thank you, Jim, for joining us.
Thank you, Erik. That's a little bit too hospitable of a gesture, but let me just, I had my HIV class this morning, and I've been teaching this since roughly, I'd say 1990, and in one way or another. And here at BC, I think it's a kind of a course that really enables people to appreciate public health. So just a little background. When I teach the course now, I teach it alternating with Kristen Heyer. She'll be teaching it next year. She taught it last year. We alternate with one another. My way is that I leave it at 10 students to enter the course, and then I make space for another 30 to 40 others who I do gatekeeping. And so I have a lot of people who are in public health, global public health, or in medical humanities, but most have come with some background. So it's a very exciting class to be in. And we now have adjusted our course that we do COVID-19 at the last 20 minutes of the class. So it's a course really on 2 pandemics. So let me just I thought I would make some points about one thing about HIV, just some data. 2, where I think that things are different right away between the two, but where I see similarities. And I'll try to stay at about 7 minutes, 8 minutes, just to put that out there to see if that generates comments. I'm scared to death with having Phil and Nadia there because of their competency, but let's go ahead. So first, some background on HIV. I thought some data would be good. There are 37.9, this is a 2019 UNAIDS fact sheet. There are 37.9 million people living globally who are HIV infected. 37.9 million who are living globally with this virus. 1.7 million new infections in the year 2018 to appreciate 2019. We live in a world that has grown accustomed to these numbers. Everybody here, we're all very watching numbers, but the numbers on HIV are so strident, and our way of so-called living with it, I'm going to come back to later. There are 24.5 million people who are receiving treatment. But that means, therefore, that there are 12.5 million to 13 million who are not receiving treatment. So 24.5 million of the roughly 38 million people are receiving treatment. That's an enormous accomplishment. And that's an enormous financial burden. So the fact that we still have 1.7 million new infections in 2018 gives you an idea of how problematic it is to prevent this. So the first, that's to give you some data. The second is some background in terms of what were early things. One of the first things that I thought of was that the president of the United States refused for 18 months to acknowledge HIV. You know, like a number of people have said, at least Donald Trump couldn't do that. But I mean, it is really astonishing when you think historically that when HIV broke out for 18 months, the president assiduously avoided any comment on it. It gives you an idea of how we kept that virus outside of our way of looking. We also not only had that way of preventing us from considering it, we also had stigma. One of the things that I'm looking for now is to see where do I see stigma happening. But the stigma of HIV, because it's transmitted through sexual activity for the most part, other than the exchange of blood, for the most part, it has allowed people have had permission to use stigma. And there's so much work in our course that we do on how problematic stigma is, that there's at least, you know, that at least with this virus, the level of stigma is nothing like it was with HIV. I mean, with HIV, it was horrendous. Another thing that's different between the two of them is transmission. You know, transmission, two differences. One is that, you know, that this is a virus, HIV is a virus transmitted for the most part through sexual activity or through the exchange of needles or some other exchange of fluids. But what's very important to appreciate, this is so striking for me, that, you know, if you nick yourself, say you cut yourself and a drop of, and you're HIV infected and a drop of your blood falls on the table, you know, people get all anxious about it. In 5 seconds, the virus is gone. It's a very, very, very fragile virus. And when I see what COVID-19 does, what that virus is like, it scares me to death. You know, when you think of the HIV virus cannot stand exposure, and they have had 75 million people affected by it, with 32 million died. 32 million people have died, and now and we still have this high population that's infected. All of that with a virus that was not, that was very fragile, that didn't have the wallop that this virus has. So if that doesn't make you unsettled, that's what keeps me really striking. The similarities are coming out now every day in the United States. The famous article in the Times 3 days ago about African Americans population really being, you know, bombarded by this virus. The question of inequity, the question of instability. Vulnerable populations remain vulnerable wherever they are. And whether you're talking about HIV or you're talking about COVID-19 or you're talking about SARS or Ebola, vulnerable populations are the first that are really that are there. And for the longest time, we all thought, in our stigmatizing way, we thought that HIV was, if we just tried to shame people about sex, then nothing would happen. We had no appreciation of how sex functions in life, none whatsoever. So we weren't paying attention to women in households where they have no power, no equity, no capacity to make, you know, decisions that, or that their cultures didn't support them. Real major issues about how some populations are not able to protect themselves the way others are. That question, strikes me as the crucial question in terms of ethics, is the protection of these vulnerable populations, and to understand why those populations are vulnerable. So Fauci's remark that these people are going to be with us at the end of this too, if they survive, this is really key, because these are the structures that we have to look at. And that's what I want to conclude on. With HIV, you know, I'm on this campus. HIV, it's far from here. Even though there's 38 million people infected, it's far from here. I think that this virus is bringing in the precarity of the world to those of us who are privileged. I think that 2/3 of the world lives the way we're living now, all the time. Precarity is part of human life, but not in the industrialized world. We've tried to eliminate, by stabilizing practices, precarity. And there's something about this that's forcing us to look at how precarious health is in the world. Last week on Palm Sunday, the Pope said that the world is sick. 2/3 of the world knew that. Now the whole world knows that. I think this is a key insight for us today, that if we really want to pay it, I find it fascinating how little attention our government gives to public health. And when people start asking, why are we in this situation? Because we have been giving so little attention to public health. I think that that's really rather key. We've made it a commodity health, a capitalist commodity, instead of something that has to be governed by the common good. It has to be something that we're all interested in. And I think that with HIV, we were able to keep it at bay. We were able to keep it outside of our framework. And this virus, we couldn't, but we thought we could. And I think that but we thought we could is a lesson we have to keep asking ourselves, why did we go that route? Why were we so unprepared that we actually didn't think that this was going to happen? And so one of the things that the Pope says when he talks about the world being sick, he's talking about climate change. And he keeps doing this. He keeps trying to bring climate change into this. He believes that if we realize how vulnerable we are to COVID-19, maybe we'll realize how vulnerable we are to the issue of climate change, and that we're not going to be living under this glass bubble that we did before this virus arrived. So that's my pitch.
Thanks a lot, Jim. I appreciate you being here and running over from class, and thanks for those really
well, actually, I was
comments.
still sitting in the same place.
Oh, that's true.
I've had two courses and meetings in between, so yeah.
That's right, sorry. Nadia or Phil, do you have any comment before we turn out to the questions in the audience? And of course, I encourage those of you in the audience to type questions in the chat bar or raise your digital hand, and we'll let you have your screen to ask them.
Yeah, I'd like to pick up on that last thing that Jim just said about the parallels between climate change and COVID-19. I've been I do a lot of work, as you know, on climate change and pollution and those sorts of issues, and talking to colleagues who are in the same space. And we've been struck by the parallels between them, the shared vulnerability, also the similar ways in which political leaders have reacted to the two, denying the existence of the problem for as long as they could, minimizing it after that, and taking action only late and only grudgingly. And some of us are in hopes that we can point to this parallel and stimulate some action against climate change before it too spirals out of control and emergency rooms are overwhelmed. To be continued.
Thanks.
Nadia, do you want to jump in?
Yeah, I mean, I'm so glad that you're here. I'm glad that you shared.
Likewise, Nadia, I've been following you regularly these weeks.
Well, it seems like our ideas are actually, you know, quite similar. I wrote a piece that hopefully will be published in the next week or so on this idea of how we've managed to keep our distance from disease for so long. Yeah. And now we are sort of faced with it. And the way that we react to this will really indicate how much it is that we value those who are vulnerable in our society, how much it is that we value public health. And so I think our thought processes have been quite similar, and I'm grateful that you're here to help us.
We should do something together on that.
We should, absolutely.
I'm ready. I am really ready for, yeah.
I'd love that.
Yeah, good.
Well, so let me ask a question then on the same topic. We know that when faced with vulnerability or threats, people in this country act in very different ways, both in terms of politics and in personal action, at the neighborhood level, at the home level, and in terms of politics. What can we say about ways in which we might speak to the broader public to encourage reflection on vulnerability and action about shared sacrifice in ways that are holistic and constructive, but don't ignore the fact that one response is to build walls, hunker down, keep distance, and don't send foreign aid. Those are real political reactions, and in some way a natural human reaction to try to protect the things closest to you. How do we talk with each other and in broader public spaces about solidarity amidst all of this, and as we look forward to November, but also the times when the United States needs to be offering its resources globally to other countries as they're facing this without anywhere near the resources we have in terms of hospitals, expertise, etc. This is for Nadia. Yeah.
I'll go first, if that's okay. It just strikes me that we have a variety of vectors. I think, like for me, I have two hats. I'm an educator, but I'm also a priest. I think that the religions right now have to start acting sensibly. I think rather than being anxious about worship, they should be anxious about really promoting neighbor love, really being mindful of who the neighbor is, and paying attention to people like Pope Francis, who are telling us this is a time to respond. This is not a time to exclude. And so I saw somebody putting down that it's physical distancing, social solidarity. I think that we have to figure out that we're not going to survive by isolationism. That when we see our governors forming alliances, this is sensational. This is the best news we've had since we've had such a fantastic failure in terms of leadership in terms of this. So the models of solidarity, of alliances, about modeling things forward. I think of HIV. You know, when George Bush announced PEPFAR, I remember watching that. This was this man that I had considerable reservations for. I fell out of my chair when I heard him say that we were going to, and PEPFAR has done more for changing this virus than almost anything else. And this came from a man who somehow was encouraged by other people to see how we needed to proceed. And I think I think not only do we want to get with communities, but we also have to get to people in power who can affect change. And we have to figure out how strategically to elevate them and to protect them. I think right now, it's in our interest to make sure that Tony Fauci is around and has a voice, and that we should stop in any way that he's censored. These are things that we have to strategically think out. So faith-wise and as educators.
Great. Nadia or Phil, do you want to jump on that, or either of the two questions we've had that in the chat box that both reflect questions about vulnerability and about solidarity or lack thereof?
Yeah, I'm really struck by Audrey's question. It's something I've been thinking about. So for those who didn't see the chat box, Audrey's asking about, you know, if we focus on our shared vulnerability now, will those who have privilege, those who are healthy, sort of forget about that once things go back to normal? And I think that that's really a big concern. And unfortunately, we've seen evidence that that happens in society. If you think about something like the MMR vaccine, right, and this movement towards anti-vaccination, these are privileged groups of people who've been separated from those diseases for so long that they've forgotten what it's like to be infected with one of them, and they've decided not to participate in vaccination. So unfortunately, there is that precedent. I think that sort of relates to Julie's question about this idea that, yes, almost everyone in society is probably going to be affected by COVID-19 in some way, some more disproportionately than others. And perhaps that it's through that solidarity of experience, of community, of sort of a collective mourning that we're going through right now, that we might have the opportunity to do more education, to do more outreach, and hopefully to create more community than we have been able to in the past. So I agree that we need to sort of seize this moment as an opportunity to organize, but also as an opportunity to educate, especially those of us who have the education or have the experience that many I know on this Zoom call have had.
I'd like to agree absolutely with what Nadia said and take it a step further, because I think the way that, reading from Audrey's note, the way that societies sustain a long-term commitment to public health goes beyond goodwill. That sustainability is achieved by translating goodwill and a shared sense of vulnerability into structures that that survive over the years and over the decades. And what I'm really talking about here is the notion that almost every big advance we've had in public health in Western Europe and the United States in the last 100 years has taken place in the aftermath of disaster.
Yep.
So we banned DDT after Rachel Carson published Silent Spring. We passed the Clean Air Act after the air pollution disaster in Donora, Pennsylvania. And in the UK, they passed their Clean Air Act after the Great London Fog of 1954 that killed somewhere between 4,000 and 12,000 people in 4 days. We passed the Occupational Safety and Health Act in 1970 after the Farmington, West Virginia mine disaster. So what I'd like to see happen in the aftermath of this, and it depends at the federal level, it depends pretty much absolutely on how the election turns out in November. But I would like to see some fundamental restructuring of public health in this country to enhance our emergency response, to rebuild local health departments that have been starved and hollowed out for the past 20 years. The staffing levels in most state and county health departments today are about half of what they were in 1970. It's hard to believe how we've hollowed out the public health infrastructure. It's like letting every bridge and every highway in the country deteriorate for 40 or 50 years, and the consequences are the same.
One of the things that over the past couple of months, I've been reading a lot of Judith Butler. Of all the philosophers, she's the philosopher I most enjoyed. And she does a lot of work on vulnerability, where she wants to have a notion of vulnerability that's not just about need, but rather about the capacity to respond. That vulnerability does not mean to be wounded. It means that you're not worried about being wounded. You're woundable, but you're actually more interested in being responsive. So a vulnerable person is really somebody who can be wounded, but it's also somebody who can be responsive, that they're able to see and to hear this. And she talks about how precarity is a lesson for vulnerability. And so we see our students, for instance, going around and doing immersion programs, entering into precarity so that they can learn lessons. I think that as a university, we have to make sure that this is a lesson that we bring to the classroom right now, that the precarity that we experience is the precarity that most of the world knows as a daily experience. We're waiting to remove this, but I'm anxious that as educators, that we don't figure out ways of carrying this experience. Now, of course, we're gonna have this virus until we have a vaccine. And God knows when we really will have a vaccine. And I imagine that we'll have all sorts of different types of approaches that have happened in with other issues of containment, which we're trying to address as opposed to vaccinating and stuff like that. But in this time, in the interim, until this virus is completely subdued, this is a time for educators to really say, we have been living in an unreal world, and penetrating the bubble. People say the BC bubble. I think that the universities have been promoting a bubble in which we do not know how the other 2/3 live. And the precarity therein is what we're experiencing. And we cannot go to a new normal that doesn't bring that lesson with us. And I see some stuff by Laura Hake here. She's posting some links to follow up on that.
Right, and we'll get to Laura's second chat question there in just 1 second. To the point that you were raising, and we're circling here about returning to Boston College, how can we think about this kind of work of recognizing what's happening around us, but also recognizing what is happening to us as a community? When we imagine coming back in the fall, I mean, I think it's maybe just as likely that we will be online again in the fall. We'll have to wait and see. But what kinds of practices of caring for one another beyond revealing the vulnerability that we're experiencing relative to the world? How do we take care of one another in that context? How should the institutional responses look at Boston College for our students, faculty, staff, and all the other people in our community? What ought to change given the lessons that we're learning?
Nadia, you want to go?
I'm not sure I have a nicely tied, response to this. I mean, I can speak from my own personal perspective. I have definitely been thinking about how it is that I will personally change my teaching moving forward, what I will prioritize in the classroom, how I will bring different voices into the classroom, how I will be caring for my students differently in the future. I mean, these are all ways in which I know that this will transform my interactions with students. And I definitely think that there needs to be institutional level changes that occur. That might be beyond my pay grade.
I think that we're also called to be more disruptive. Like I was thinking of how I got through the holidays with family members and a variety of other people. We all managed to just dodge the bullets that were constantly going around because we wanted to make sure we got through the holidays. I think we have to pay attention to the world. We have to be responsive to the world. We have to be speaking out. We have to speak the truth. And I just am concerned that there is a certain way that we as educators placate one another with the delirium of we all love one another, when as a matter of fact, one of the reasons why we're dodging the bullets is because they're aimed at us. So I would like us to have a new truth as educators, that we're in a real world that is much more vulnerable than we antiseptically make ourselves believe. There has to be a new honesty.
Thanks very much, Jim. In the few minutes we have remaining, let's take up one last question from Laura Hake around the question of resisting gaslighting, or the sort of the conversation to come that will be both loosely popular, but also directed and very strongly backed by some organizations and government officials about why we need to return to normalcy and why things ought to be back to the same. I think that's the direction that Laura is posting here about the ultimate gaslighting effort that's to come. Do you have, do our three panelists have, I know Nadia, you actually need to leave here in a second. So if you want to speak quickly, you start, about resisting or properly interpreting or understanding the new context that we'll be in pretty shortly about that pushes against the sense of the common good.
Yeah, I guess I'll say something and then thank you, I have to head out. But I guess one thing that I hope this gaslighting doesn't do is I hope it doesn't ruin our trust in science and in health. And I hope that whatever decisions we make moving forward, hopefully we can keep those rooted in good science and good public health knowledge. And I think that that is going to be a big fight for those of us in this field. I don't think that, large corporations are going to want to listen to the good science. And I think we need to be the vocal ones to stand up and say, this is what the science is saying we should do. This is what public health officials are saying we should do. And that's going to be a really difficult fight, I think, moving forward. So thanks for having me. I'm sorry I have to head out, but I hope to see you all next week.
Thanks, Nadia. Thanks for joining us. Phil or Jim?
I'll just echo something that Jim said a minute ago, and that is that we all have a responsibility to speak the truth and to speak truth to power. There's a lot of people making up facts these days, and there are media organizations who are organized to put out those distorted facts. We can't change that, but we can continue to speak the truth and do it as loudly and as effectively, and use our various social skills to disseminate what we consider to be the truth as best we can. I don't know what else to say.
I guess I would just add one little concrete detail. One of the things that we've been talking about in my class is patenting. The patenting of antiretrovirals, the patenting of Truvada, patenting, and how corporations have in their research managed to charge enormous prices. When we look at this vaccine and other different medical solutions that we may have for treatment and for prevention, it strikes me that we have to be attentive to what happens with the patenting and what will happen with pricing. I think that as we watch this, that the Daily Post from about 9 days ago about the race for the vaccine, there is an insidiousness that's going on right now about pharmaceutical interest in trying to alleviate this. And we have to raise that consciousness about this, because when the vaccine is made available, we have to make sure that it's made available.
See the column today in the New York Times by the husband-wife team of, of Nobel laureates, Deaton and Case, who spoke precisely to that point.
Oh, good. Thank you.
Yes, and I think as we move forward the next few weeks in this conversation of our fireside chats, we'll also, want to be turning to how we support our communities through, small businesses and people who need to get back to work as well. What are the safe and important ways to be in support and care for our communities as the doors start to open slowly, and how to be thoughtful about that. Next week, we'll have the Dean of the Nursing School, Susan Gennaro, join us for a conversation. And I think the week after that, our final week of these chats, we'll be bringing a physician from the Global South that Phil and I had spoken about early on. So we'll continue with this, and maybe we'll find a resource board to share with people as well. Thank you all for joining us today. As always, thank you to Phil and Nadia, and thanks Jim Keenan especially for jumping in today after your class. This is a really important part of the ongoing understanding of what's happening around us for me, and I know it is for the people who join us on the call, and the hundreds and hundreds of people who've been watching these videos online as well. So thank you all for being here. We'll be here next week as well, and this recording will go up probably on Thursday morning through Boston College's YouTube channel. Thank you very much. And
thank you, Erik. You're a model of what we need.
Yeah.
Thank you very much, Jim. Thanks, Phil. Take care, everybody.
Bye-bye.